it's very tempting to say acalabrutinib comes with less bleeding, comes with less this and less that and less the other. And certainly there was less severe bleeding with the acalabrutinib relative to the ibrutinib treated patients. But there were also slightly less patients who were anticoagulated. And when we start thinking about minor bleeding rates, contusions, petechiae, epistaxis, and so on, they look the same. And when you really start asking then, well, is one drug better than the other when it comes to bleeding? I would argue they're pretty similar. And I wouldn't make a decision based on that. One thing that I should have hit on in the presentation, which I didn't, was another very important observation. Roughly half of the ibrutinib treated patients were still on anticoagulation, and around 40% on the ACALA study, meaning, guys, if you need to anticoagulate, you still can. You just have to be aware of the risk. And that is something that gets overlooked very, very commonly. As we think about more specific side effects, we saw more headache with ACALA, we saw more atrial fibrillation, which you could argue gives the treating doc a headache, on the ibrutinib study. And that's really about it. Otherwise, myalgias, diarrhea, all pretty much in line with one another. And again, I'm not saying they're exactly the same. I don't have a p-value to compare these things, but you look at the rates, they're pretty similar.